Before I turn to the presenters to share with you their thoughts about what's now and what's next, I'd like to start by saying thank you. As Housing California Board Secretary, I want to express my deep gratitude to Housing California's amazing staff and to each and every one of you. Thank you so much for your time. We've made it to the fourth day of the unconference at a time when we're experiencing in grand scale uncertainty, unyielding systemic and structural injustices, and I would add unbearable suffering and anguish, especially endured by all our sisters and brothers who are most vulnerable and who have been wronged. I want to thank you for your heart because we see you and your goodness, the talents and treasures you bring to the movement, including your unabashed strength and compassion, and the unrelenting ways you show up day in and day out carrying the torch of hope. Thank you for your commitment to action and all that you do to lift up our common humanity, pushing the boundaries of what we mean when we say home. My name is Rochelle Reyes-Fenger, and as an immigrant from the Philippines, I come with a narrative that sees home through a lens of what has been lost and left, what can be recovered, and what can absolutely be reimagined. It's a pleasure and honor for me to curate this workshop with thoughtful conversationalists who not only talk the talk, but who have absolutely demonstrated boldly walking the talk. It's our hope that you may come away inspired and renewed because you deserve nothing less. A little bit about what I do in the organization I'm privileged to work for. I'm the System Vice President of Public Policy and Advocacy Engagement for Common Spirit Health. As a private not-for-profit, we have 32 Dignity Health hospitals in California, and we're the largest Medi-Cal provider in the state. Our healing mission spans across 21 states, and I have the distinct responsibility for advancing our public policy and advocacy priorities on social and environmental drivers of health, including giving voice to the housing and health connection, and what our part is as a healthcare system to lead on transformative policy solutions in the communities we serve and in the state and national advocacy arenas. Nothing of what we do in the health equity and housing space can be done in isolation, but in meaningful partnerships. Dignity Health's commitment goes beyond providing acute care. We're addressing housing insecurities through a multitude of efforts through our Homeless Health Initiative, focusing on need in rural communities and strengthening collaborative efforts to improve coordination of care and access to community resources. Altogether, we've awarded in fiscal year 20 $9.2 million to dozens of projects addressing homelessness prevention and provided loans at below market interest rates to nonprofit organizations and developers. All the while, I can't underscore enough the unprecedented challenges the healthcare sector faces during this COVID era. The why for us is clear. Health is housing and housing is health. We're acutely woke to the fact that California's health is at risk without a stable, affordable place to call home. Californians who experience homelessness are twice as likely to get sick from COVID-19 and 2 to 4 times as likely to die. Before the pandemic, and even as we look to get past this pandemic, we know that health challenges for people experiencing homelessness are far worse, and the economics associated with that unnecessarily cost higher. And according to the National Alliance to End Homelessness, 84% of unsheltered Californians suffer from physical health problems compared to only 19% of those who are sheltered. The same disparities exist when it comes to mental health problems and substance abuse. Families, including children living without shelter, lack adequate sleep, hygiene, and more than half suffer from food insecurity. And of course, people who are forced to live together in encampments or RVs can't safely socially distance. Top of mind for policymakers when addressing health is to address insurance, co-pays, prescription drug costs. These are critically important, and so is the focus on prevention and social health. This must also be top of mind to address. We need humane, healthy living conditions that can only come with the home. And we know that the most effective vaccine against COVID-19 right now is sheltering safely in place in a home. And our speakers understand the importance of housing as a social determinant of health and the power of multi-sector approaches to build off of community assets, synergize efforts, and leverage resources for greatest impact. So please help me in welcoming Dr. Douglas Juty, Executive Director of Build Healthy Places Network, a national organization with the mission to shift the way organizations work across the health, community development, and finance sectors to collectively advance equity, reduce poverty, and improve health in neighborhoods across the United States. Doug brings the community development and public health perspective. We also have with us a colleague I deeply admire, Dr. Bishara Shukair, who is the Senior Vice President and Chief Health Officer at Kaiser Foundation Health Plan and Hospitals. He oversees the organization's efforts focused on addressing the social health of its 12.4 million members and the 68 million people who live in the communities it serves, including over 1 million Kaiser Permanente Medicaid members to meet their housing, food, and transportation needs. Dr. Shukair is also responsible for the organization's environmental stewardship work, including becoming carbon neutral in 2020. And he manages Kaiser Permanente's community health portfolio, including $3.4 billion dedicated to supporting medical financial assistance, charitable care, grants, and community health initiatives. Bashar will further bring the healthcare and health systems perspective. And last but not least, we have with us Mark Trotz, who is a leader in public sector initiatives that provide decent housing environments for people who have experienced homelessness and multiple contacts within our fragmented healthcare and criminal justice systems. Mark currently works as a consultant to various local governments, and he formerly was the County of Los Angeles Department of Health Services, where he launched the Flexible Housing Subsidy Program. Mark will bring public sector, homeless on the ground experience, and innovation to the field perspective. Welcome, panelists, and Doug, let's start with you.
Great. Well, thank you, Rochelle. And I want to thank Housing California for having me. It's actually the second time I've had the chance to speak to Housing California. I spoke at a plenary back when we met in person a few years ago in Sacramento. So in my opening remarks, I'm going to give a little perspective from my role as a pediatrician and as executive director of the Build Healthy Places Network. And our work has really been around working across sectors. So I think the biggest takeaway that I wanted to bring is that housing and health is now a movement. And in fact, the COVID-19 pandemic has only accentuated its importance. The network was founded to support and encourage greater collaboration and partnership across the health and community development sectors. Because as Rochelle just said, housing is health, and because strong communities are health. When I started this work 10 or more years ago, social determinants of health was not even a term being used among housers. Health wasn't a focus of housing, and housing honestly wasn't much of an interest area of focus for healthcare. In fact, early on, when I spoke with the Robert Wood Johnson Foundation, the largest health foundation in the country, they said, look, we don't do housing. And now they funded me for a number of years because housing and its role in health is so clear. As recently as just 5, 6, 7 years ago, there were very few examples of healthcare investing directly in the development of housing. I would repeat the same stories over and over again. In fact, one of them is Dignity Health. Very early on was making direct investments. I'd go to Avita Health and Wellness in Stamford, Connecticut, Nationwide Children's Hospital in Columbus, Ohio, and that was sort of it. But it's really changed. It really has become a national shared value. So the numbers of examples are amazing. Kaiser Permanente is a prime example, and you're going to hear from Dr. Shukair about the scale of their investments. We've got, and I'm just going to list a few just to give you a sense, ProMedica in Toledo, Ohio, Adventist Health in Orlando, Florida, Atrium Health in Charlotte, North Carolina, Consortium of Hospitals in Portland, Oregon, Trinity Health in the Midwest, Boston Medical Center in Boston, and even in Assure, United Healthcare in Phoenix. And every single case, they are directly investing in affordable housing. In the Bay Area, Dignity, as I mentioned, and Kaiser Permanente are really primary players as well in Sacramento and elsewhere. Providence St. Joseph is working in the high desert and other areas, and we're seeing early work in Fresno, Stockton, Coachella Valley, and a lot of interest in Los Angeles. Even UCSF in San Francisco, a big academic medical center, is trying to figure this out. In some respects, some of this is related to, and I want to mention the sort of second major point, is the role of the healthcare anchor network. So Kaiser Permanente, Dignity Health, Public Health Institute, which is my fiscal sponsor and where the Build Healthy Places Network is based, played key roles in the creation of what's now called the Healthcare Anchor Network. There's at least 45 or more members. These are healthcare systems nationally, and they tackle what's called the anchor model. And I think this is important for our housing audience. The anchor model means that an organization, institution can't get up and move away. You can't pick up a hospital and put it in Mexico or put it in Canada or put it in Thailand and still take care of the patient. So you're stuck there, you're anchored. This is also true of universities and colleges. And the anchor model is, what's the role that a local organization can play in the local economic environment? It comes down to three main things: hire local, buy local, and invest local. Hiring local, of course, is about the local residents. Buy local is procurement, and invest local is sort of where I sit. Recently, the Healthcare Anchor Network made a commitment, many of the organizations, to up to 1% of their investment portfolios towards community investment. That's $700 million just among those 45. It's not enough to solve the problem, but it also, as my grandfather would say, it ain't peanuts. And what if every healthcare system across the country did that? What if every healthcare system in the Healthcare Anchor Network were able to pull that off? What if it was 2%, 3%, 5%? It's still a relatively modest amount. They're still getting financial return. And as we know, they're getting a health return. The important note is that this investment is not a community benefit. This is not coming out of the healthcare grant making, which, by the way, right now is under a fair amount of pressure, that community benefit dollars, because of the pandemic and increased uninsured. It's also not healthcare dollars. There certainly are efforts to move healthcare dollars towards things like housing, but it's still very heavily regulated. It's coming out of their investment portfolio. It makes the case that housing is a safe, although relatively low low return investment. And that's where I think many of you are able to make some case. You know, there's a return on investment. It may not be a hedge fund, but it absolutely is a safe, solid investment. It's not junk bonds. It's not penny stocks. There remains a little bit of a misconception from my experience on the healthcare side that investing in low-income neighborhoods can be relatively risky. I'm on the board of Mercy Housing. I'm on the board of Mercy Community Capital. Our investments are so secure, I sometimes finding myself asking whether we should be taking more risk, because that's actually what we're supposed to be doing. The default rate has been zero for them for years. So it really is a safe investment. That's a lot of what we talk to healthcare systems about. There's also, the next point is really about the growing recognition of shared goals. Healthcare wants healthy communities. Community development and housing wants healthy communities. And when we talk about tackling or discussing how to partner with health, we talk about three main categories: mission, regulation, and cost savings. So mission is really about, in my mind, you all as housing folks, helping a healthcare system or even a public health department achieving their goal of community health and well-being. It's in all their mission statements. We can help them do that. Regulation: hospitals, as we know, are now required to complete community health needs assessments and community health improvement plans. Most healthcare systems recognize that housing is a critical issue, especially in California, and yet they don't always know what to do about it. All of you are well positioned to help with that. And finally, the cost savings, that's a trickier one. Healthcare tends to focus on medical outcomes because, of course, we're doctors. We take care about medical outcomes, but those can take years, decades even to develop. Many of you are in the neighborhood stabilization business. You're in the individual and family stabilization business. You create hope and opportunity among low-income people and communities of color and marginalized neighborhoods. We know in health and public health that hope and opportunity are tied to better health outcomes. We should be measuring that as evidence of your success and know that medical outcomes will arrive later. So I want to just turn, the last sort of major comment is the role of healthcare goes beyond money. I think sometimes, as we say, there can be a conflation between health and healthcare. Health is your wellness. Healthcare is an industry that's developed to help people fix disease and maintain their health. But it's more than just money. I think we can sometimes on the housing side think that there's so much money flowing around healthcare. You see the dollars in the news, trillions of dollars, but they're not banks. They don't want to be thought of as banks. So that's not the way to do it. It's really about developing trust and shared goals. So we think about a number of ways in which healthcare systems, hospitals can help you achieve your work with the homeless and with affordable housing. And they fall into a few buckets. First is data analysis. I'm going to start from sort of the easy to the harder. Data analysis. Hospitals have that capacity. They have health data. There may be ways of sharing their data. Second is political and community clout. They're often very well recognized, very politically connected and respected organizations. So things like zoning they can help with, NIMBYism, overcoming local resistance, especially in higher income neighborhoods. Grants. We talked about community benefit. One could also consider approaching or having a conversation about a repayable grant, a zero interest grant. Real estate. Hospitals own a lot of real estate. They're building new hospitals, especially in California, replace the old ones. Telehealth is changing the way we're using buildings. Land ownership. Could land be used differently or more effectively? Hospitals could also could discuss, healthcare could consider loan guarantees or credit enhancement. It's not yet making a direct investment, it's backing up existing investments. Then you get into the more complicated, although I think Dignity again and Kaiser are getting there. Short-term loans, revolving lines of credit, bridge loans. Dignity Health and others have created the San Francisco Accelerator Fund, for example, to help the city capture properties before the private market does. Pooling investments, multiple systems, or potentially through a community development financial institution. And finally, the most complicated, which is where it's the sort of the last, is the actual direct investment. Although when it's possible, 1 or 2 or 3% interest loan can be really important for all of you and your work. So to close, I'm just going to mention a few tools that we've been working on to help all of you sort of make headway on this. The first is what we call the healthcare playbook for community developers. So it's really reviewing some of what I just described about figuring out where is the healthcare system in their process of thinking more broadly about neighborhood investment. We have several tools, Jargon Buster, getting the language. Equity means something very different when you're talking about race, health, and financial equity. Partner Finder, who are the local partners in your neighborhood, both for my public health colleagues to find community development and housing colleagues, and the other direction. We have Measure Up, which is a collection of some of the best metrics, some of the mapping tools, and some description about how to use them best. And this work is fun, it's exciting. And so our newsletter really gets to that, our essays and case studies. And I'll finish, the last one you guys might find intriguing is something we call it the ROI report for short, but it really, it dug into and used public health literature to show that a $90 million investment at a substantial, it's called the Conway Center in Washington, D.C., was able to recoup 300%, threefold in return in health return. So that starts to make the case as well. There's many different ways of seeing a health value for addressing housing and homelessness. So that's a lot of material. I'm going to have a chance to talk to you more when we get to questions. And so I'm going to turn you over now to Dr. Bashar Shukair from Kaiser Permanente.
All right, thank you so much, Doug, and thank you, Rochelle and Mark, for having me join this conversation. And I'm really excited to be part of this discussion today. And I serve as the Chief Health Officer at Kaiser Permanente, and for the 75 years that our organization existed, we've been about the same mission, and it's about improving the health and well-being of our members and improving the health and well-being of our communities. And we truly believe that those go hand in hand. So if you think about it for a moment, there is no way we can deliver on our mission to improving the health and well-being of our communities if we don't do a really good job at improving the health and well-being of our 12.4 million members. And at the same time, there is no way we can optimize the health and well-being of our 12.4 million members if we don't focus on the conditions for health and equity in the communities where those members live. And when we do that, not only our 12.4 million members will benefit, all 68 million people who live across our communities would be able to benefit. And when we think about conditions for health and equity in our communities, housing is an integral part of that. I think we all agree, particularly all of us on this conference, that we can't expect people to live healthy lives if they don't have a stable roof over their head. And year after year, and research after research, and study after study, and honestly, just common sense will tell us that that makes total sense. You know, I'm a family physician. I trained in a healthcare for the homeless program in Houston, Texas. I practiced in healthcare for the homeless programs in Illinois. I ran a healthcare for the homeless program for Chicago, and I have seen it directly, day in and day out, that if we don't support people in making sure they have a stable roof over their head, it's almost impossible to expect them to live healthy lives. And we know from research that life expectancy for people experiencing homelessness is about 27 years less than those who are housed. Think about that for a moment. 27 years less than those compared to those who are housed. We also know that if you're homeless and you get admitted to the hospital, chances are you're going to stay 2 to 3 days longer in the hospital. We also know that once you're discharged from the hospital, your chances of being readmitted to the hospital is about 50% higher than those who are housed. So we know that this connection between housing and health is there, and we want to make sure that we are thinking about this more proactively. We're engaging on how to make a difference in the space, and how we're partnering with community-based organizations, with housing providers, with local, state, and federal government, and making a difference. So as an organization, we've made a commitment a couple of years ago to really step up our work on housing, and particularly on the interface between housing and health. And we knew that to be able to do that, we had to bring significant resources, and we have to also bring our voice to the table, and come into the table with humility and a lot of curiosity, and being able to partner with people who've been doing this work for a very, very long time. So back in 2018, many of you might remember, we've announced a $200 million commitment for impact investment to preserve and expand affordable housing in our communities. And that was a pivotal moment for us as an organization, where, similar to what Doug has just described, we've partnered with our Treasury Department and said, could we carve out those $200 million, and instead of investing those dollars in the market for return that would help us with advancing our affordability agenda, can we invest those dollars in projects and efforts that would allow us to preserve or expand affordable housing in our community? And so much progress have happened since then with those investments. We were able to close on over 33 different properties across our footprint, and we able to preserve or add about 3,100 affordable units in our communities. But we also knew that impact investment is one tool in our toolbox, and yet we needed to think about other opportunities and other ways to engage. So we've partnered with an organization on an effort called Built for Zero through Community Solutions. And in that effort, we've partnered with about 24 communities across our footprint, and we're working through a methodical, evidence-based approach with Community Solutions to be able to get us to a by name list, community by community, and be able to close the gap and make sure that people are getting housed, getting off the streets with a systematic approach. And we're making really good progress in many of these communities. I would encourage you to check out the Built for Zero concept or communitysolutions.org if you're interested in learning more about this effort on the ground. And we also knew all along that policy and advocacy is going to have to be a key part of that effort. So we've developed an effort that's focused on big cities. We've partnered with states on efforts in states in our footprint, particularly in California. And we've also partnered with a coalition on a federal level. So just briefly, on a city level, we've partnered with the De Beaumont Foundation, and we've created an effort called City Health. And this is an effort that's engaging the 40 largest cities in the country, soon to be 75, on a set of evidence-based policies that we know local government could put in place that would make a difference on the long run when it comes to lifting up community health. And one of these policies is around inclusionary zoning. So we're really excited about how this effort is evolving, and soon we'll be able to add some additional elements around the housing portfolio. At a state level, we've partnered on a couple of the propositions here in California, and we've worked with a couple of the other states where Kaiser Permanente operates to make sure that we're adding and increasing resources that are available to address the housing and homelessness issue, and looking also at the intersection between housing and health. And then at a federal level, we've partnered with a coalition called Mayors and CEOs for U.S. Housing Investment. This is a coalition of 24 bipartisan mayors who came together with CEOs from those big cities or from those cities and communities, and they've created an agenda at a federal level that advances the need or pushes for adding the voice to increasing investments in affordable housing, increasing investments in programs that we know work to prevent homelessness or ensure housing security. So we're really excited about this effort. Kaiser Permanente is the national partner for this coalition. So we knew all along that policy and advocacy has to be an integral part of this work. And then we knew that we had to be on the ground doing work to make a difference. And one of the efforts that we're really excited about is partnering with Governor Newsom and Project Home Key, that's dedicating resources through the CARES Act to support local government to be able to purchase motels and transition them into affordable housing. And Kaiser Permanente was the first private sector organization to come in and dedicate $25 million to support this effort by providing all the wraparound services that are needed once you transition folks and get them into this affordable housing. So we're really excited about this effort. We think it's an important effort to increase availability of affordable housing stocks in our communities. And we know that if we don't provide the wraparound services, it's going to be a big challenge to be able to preserve the housing status of folks who are going to be able to benefit from Project Home Key. So we're really excited about our housing effort. We truly believe that housing and health are so interconnected. And I'm going to end by just reflecting on something that's so critical in my mind. I think when you go upstream to address the root causes of poor health, we invariably encounter problems fueled by systemic racism and inequity. And when we think about economic inequality, racism, and other form of discrimination, societal neglect or investment, these are really the underlying factors that are creating those conditions that are impacting the health down the line. And we've seen that, we see this day in and day out at our organization. I'm sure we see it in our communities every day. And one example I'd want to highlight, last year we've made a commitment to partner with the Bay Area Community Services, BACS, in Oakland and in Alameda County. We've identified 515 people, 50 plus, who have at least one chronic medical problems who are out on the streets in Alameda County. And we said, what would it take for us to be able to take all those 515 people, get them off the street, get them into permanent housing? So we created a flexible pool funding that allowed BACS and BACS outreach worker to tap into this fund for a very specific set of funding barriers, if you want, to remove barriers to getting those 515 people that we knew by name, get them off the street. And in a matter of 9 months, we were able to get 515 people off the street, get them into permanent housing because of the creation of this fund. But one learning that I thought that was very critical through this effort that I want to lift up around inequity in this issue, we knew that 11% of the Alameda population is African American. When you think about the homeless population in Alameda County, 47% of the population is Black. And when we looked at that 515 people list, and those are, remember, the 50 plus have at least one chronic medical problems or more. When we looked at this population, 85% of this population was Black. So I'm going to end by just reflecting on those three numbers: 11%, 47%, and 85%, to really lift up the issue of equity and how important it is as we're thinking about housing and health to keep the equity lens front and center. So with that, I'll end my remarks here and I'll turn over to Mark, and I'm looking forward to the discussion after Mark's remarks.
Hello, everybody. Thank you, Bashara, and thank you, Housing California. I'm really happy to be here, and I love the way Bashara ended with his remarks using the BACS example and housing 550 people in 9 months. Or so, because that really plays into what I'm here to talk about. I'm going to be focusing more on sort of on the ground change, but it's all undergirded by what Doug and Bashara have been talking about. And I share Doug's sentiment, how nice it is to hear the connection between housing and health become just part of the vernacular. And again, you know, stating the obvious, how important it is, how housing, having a roof over one's head, is just so fundamental to everything we do beyond that. For all of our other healthcare interventions and other support that we provide, if you don't have a place to live, it really doesn't work. So that, you know, that's, I think, something we probably all agree with. So I'm here to talk about the California Housing Stability Benefit. Now, don't go pulling out your phone and trying to Google this, because it doesn't exist yet. Okay, this is a moment that we want to have with you right now to sort of, and the concept that I'm going to discuss this morning is really the result of an ongoing conversation that a bunch of colleagues are having in California. We sort of meet on Zoom every 2 weeks, and we've been sort of discussing what's next. And you know, the people who are meeting are folks that many of you know, and we come from different parts of the sort of homeless housing work. Some of us are ex-government workers like myself. Others are researchers. Others are affordable housing developers or former affordable housing developers. But I think what we're really sort of yearning for and talking about in our meetings is, and recognizing, is that what we're doing isn't working. And I'm not here to be like the downer, because this is not a criticism of everything. or any body or any organization. I'm part of it, you're part of it, we're all part of it. But if we open up our eyes and are as honest as we can be with ourselves, we've been working at this for 25, 30 years, sort of the rise of homelessness and then the sort of entrenchment of homelessness and the phenomenon of people living on our streets in our cities and in rural areas. And here we are in 2020 with 150,000 or more people living on the streets, and more than that, on the verge of becoming homeless every day. So our discussions are really about how do we ensure that, in 10 years from now, in 5 years from now, in 10 years from now, in 20 years from now, at conferences like this, we're still not talking about the same issue. We're still not saying, how is it that we have so many people living on our streets and on the verge of losing their housing? So what this thing that we've tentatively named the California Housing Stability Benefit is really trying to look at what is actually needed to make real improvement on the ground. And this is not about some new intervention, some, reslicing the homeless and ELI pie to figure out what is the next priority population. It's really about math, and it's really about looking at what is the essential and the most simple thing we can do to quickly move the needle. And so we're trying to raise to the fore the idea of what would a housing benefit look like in California. And if you look at the math, a homeless person earns between $0 and $900 per month. And in most places, you can't get a studio or one-bedroom apartment for less than, $1,100 or $1,300 a month. So that person doesn't have the money to get off the streets. Similarly, with people who are housed and who we're trying to prevent from becoming homelessness, there's a high degree of the low and extremely low income populations are paying 50, 60, 70, 80% of their income towards rent. You don't need a fancy algorithm to know that if that person doesn't receive some sort of housing financial aid, they're going to be the next household that's homeless. So we're here to kind of posit, and I'll be interested in the conversation that we have to sort of unapologetically assert that that we think the only way in the medium to long term to stem the tide of homelessness in California is to develop some kind of simplified housing rent benefit that goes to a defined population. And again, this isn't a fully baked out program here, and we're not here to say it's for this exact percent of median income and this percentage of people over, but we all know that there are different ways to define a population or to define renters in California, or it's sort of our assertion that the most inexpensive and the most simplest way to do this over the long haul is to have some sort of benefit. And we do have, obviously the state and the nation has much experience in providing benefits of all sorts. The state of California provides benefits through CalFresh, through IHSS, through CalWorks, and so forth. And so we're envisioning some sort of mechanism in which the parameters are set. There's a simplified way in which someone becomes eligible for the benefit. And in this sense, I often think of Covered California or some other situation. I think, you know, right now the paradigm is that there's hundreds of different ways people can get a rent subsidy, but they're very highly stratified. And in many cases, the person that you're working with to try to get that rent subsidy doesn't fit into all of those boxes. So what would be a different paradigm? Could it be something whereby working with a case manager, working with yourself, using your own initiative, that you can get onto a web-based benefit platform and get eligibilized and get determined for what level of housing benefit do you qualify for? I mean, I think the sort of basic elements and the core elements of something like this are that it's statewide, that the eligibility requirements are very simple and clear. And, you know, depending on how something like this would roll out and the money available to do it, the size of the population that is eligible for it could start at one level, it could grow. Obviously, the larger the eligibility framework, or the broader, the more people apply, the more progress we make, the more prevention we have, the more people come off the streets. The smaller, a more restricted eligibility set of requirements would be less expensive, you know, slower progress and so forth. These are all things to be discussed, but nonetheless, the concept is the same. And then we're also talking about, if we do something like this, and you know, a lot of this is based on some of the experiences I and others have had in Los Angeles, that when we brought a flexible housing subsidy pool, similar to what Bashara was talking about, to Los Angeles, that we were able to find housing for people. And so it's not always the abject lack of money to do this. It also has to do with how flexible and how creative we're being about trying to find a housing solution for people. So another hallmark would be, you know, not necessarily what we know from a Section 8 type rent subsidy, but something that really encourages maximum creativity, taps into the strength of the individual, and looks at potential family options, looks at shared housing, looks at regional housing. Maybe someone can have a better life and live in the county next to them, and maybe that's where they have their roots. And we all know that existing systems are very rigid around all of that. So how do we sort of unlock that creativity and tap into the full spectrum of housing options that people can use? And, you know, and also maybe this is a variable rent subsidy. So it's sort of the minimum effective amount that someone needs to stay stable in their housing or to get off the street. So it's not necessarily a one size fits all. And then again, the concept something streamlined. You know, as much work as we've all done in various communities, I would say our homeless serving housing system is still very complex and very hard to understand. And from the person who's homeless perspective, or to the family member trying to help someone, it's still a very difficult situation to navigate. So, excuse me, for this one part that is about paying somebody's rent, we think there's a way to do that that will get us farther faster than the various ways we're trying to do it right now. And we also think that, you know, within the state, that, you know, given the extreme real estate, the extreme gap between people's income and the cost of real estate, it's something that California is going to need for the time being to bridge this gap. And, in terms of the outcomes, I'm just going to hit quickly on the outcomes and quickly on some sort of numbers of people and cost. And, and then we can move on to some questions and so forth. But in terms of the outcomes, we would hope to replace limited, rigid, and outmoded rental assistance programs that have not been able to scale and meet the urgency of the moment. It would be unfiltered financial resources to communities that have faced housing and economic discrimination for decades, and have folks make their own housing choices. So a less paternalistic approach to rent subsidies and housing assistance. And it's tapping into the collective wealth and creativity and social activism of California to create a state in which no one lives on the streets or faces the daily stress of losing their housing. And again, just quickly looking at some of the parameters, and this is based on some numbers that the Housing Policy Research Institute put together in their Right to Housing Subsidy in California report. So I'm expecting these numbers to be roughly right, but these are probably broad estimates. But for instance, if we were trying to have a housing subsidy available to people at 50% of median income, so anybody who earns 50% of median income pays above 50% of their income to rent, has a option to live in a house or a unit at approximately up to 150% of FMR. And these are all variables that need to get played with, but this is just one scenario. There would be 1.3 million people in the state of California eligible for a housing benefit, and it would cost $10.4 billion a year to do that. Okay, so this is a universe in which everybody above whose income is below 50% of median income has an option to get a rent subsidy if they're paying above 50% of their income towards rent. That's that. On a more constrained scenario, you could say folks earning less than 30% of median income are eligible. Again, they're paying above 50% of their income. The housing unit that one is looking for has to be at 100% of FMR. Now, I don't think that this kind of mechanism would necessarily be based on FMR per se, but just for purpose of example, there would be about 940,000 people eligible for this at a cost of about $7 billion annually. So it just begins to ask the question, for that type of investment, if we could envision something that simple, could we end this nightmare that we have in California and in other places of the country where people can't live indoors or losing the unit that they have? So, and just as a point of comparison, the Department of Corrections in California is $13.4 billion annually. The whole California budget is $266 billion annually. So you begin to see what a relatively modest investment this could be. So sorry, I'm going hoarse here. So, that's what this is sort of our coming out day for the group that's been talking about this. We want other people to help us think about this. And ultimately, we want to move to something that is starting to chip away at this housing affordability and homelessness issue in real time. And this is not to say, and it's certainly not in opposition to any of all the other activities that many people are here working on. They all need to keep going. But some of those activities, like zoning reform and vastly higher levels of density and vastly higher levels of housing production, to ultimately retune the balance of housing in this state, is going to take a long time. And I think we can actually do something now. And the example that Bashara gave, examples that I've directly experienced in my own work, is that when you have a simple access to a rent subsidy that allows for great degrees of flexibility in the type of housing situation someone can move in to, people get into housing. There are housing units out there. There are shared housing. There are family members. There are large buildings and small buildings. They may not be in the exact location that someone's accustomed to or lives in currently, but not to say that they have to go far, very far, but it may be across a jurisdictional line. Maybe that's okay. Maybe it's one city over. But it seems like we really need to start thinking much more creatively about ways in which we equip people to access housing. And I think I'll leave it there and turn it back over to Rochelle, and we'll move on to other parts.
You had me at housing stability benefit. I'm not a math person, but you definitely had my interest here in seeing how this will all kind of work through. And let's bring all the panelists on, because I'd like to do a round of questions with all of us, and then hopefully answer a question or two from the audience. But I would like to ask my first question with Doug. I'm really curious about your set of principles that's looking at the intersection of health, housing, and community development. Can you tell us a little bit more about those principles and how they're being used? And then we'll ask Bashara a little bit more about his thoughts on some of the challenges and obstacles that you've faced, when implementing some of these fabulous programs. I mean, you certainly have an eye around return on investment, but where also the challenges have been in tracking that over time and how to build further from the foundational work that you've done. Would love to hear about that. And Mark, we'll bring you in to answer the big question about how this will all get paid, your wonderful ideas. So we'll start with Doug, because I think it's important to really ground ourselves in principles and to really give folks some tangible ideas about how to move things forward.
Great, thank you, Rochelle. Yeah, so the principles to build healthy and prosperous neighborhoods really arose out of an observation I'd had and my colleagues had had, that as we were working increasingly across sectors, we were seeing very similar mission statements, very similar principles, guiding lights, North Stars of organizations in housing, community development finance, healthcare, public health, small variations. But we thought, are there in fact shared principles across these sectors? And so I want to be clear, these are not our principles. What we did actually is we took the principles and other language from 35 different organizations across these sectors. We did a formal qualitative analysis looking for themes. We actually had over 200 people weighed in. We ended up dropping from 6 principles to 5, 1,800 comments that we went through one by one and tried to shift the language slightly. And so the 5 principles in the end, and these will probably resonate with all of you, and that's actually what's been really useful. First is collaborate with the community. Second is embed equity. The third is mobilize across sectors. Fourth is increase prosperity to improve health. and the fifth is commit over the long term. If those seem obvious to you, that's exactly the point, because all of you and all of your organizations are working in exactly those areas. And what we've been hearing from colleagues who have said they've used it is that it's been really helpful for these initial conversations across sectors. So someone in healthcare or public health talking to a houser or community development finance person, or vice versa, starting with these and basically sharing them. And you'll see we have a PDF online. It's a single 2-pager. Do these resonate with you? Do we agree on these? Do we share these principles? Starting there, and then say, well, what can I do to help you achieve them more effectively? And what can you do to help me achieve them in my organization and my work more effectively? So it's been good to hear that they've been useful to sort of start the conversation as a foundation, as you said, Rochelle.
Great, thank you, Doug. And Bashara is not new to any of those principles because he has made them come alive through the work that he's done with Kaiser Permanente. Bashara, can you just give us some of your wisdom in terms of learnings and the challenges that you face, but how you've overcome them to move forward with next steps?
Yeah, so thank you, Rochelle. And I think we're all familiar in the healthcare space. We always look at, very specific outcomes. How long do people live? How well are people living? Are our health outcomes equitable? And we track those and we report on those and we try to experiment. We try to enhance our work so that we can improve those outcomes. And a lot of times when we made the $200 million commitment, we've got a lot of questions about, well, what's going to happen with your return on investments? What type of return are you expecting? And I think what we've, on the impact investment side, we've made it very clear that it's, yes, we're going to invest in the market. We're going to invest in projects that are going to preserve and expand affordable housing. And we will still expect some financial return, but most importantly is we're expecting the social return. And in that type of investments, when you start thinking about partnering with your Treasury Department, thinking about both the financial return, but most importantly, the social return, and be able to quantify those, I think is going to be really, really critical. And you can do that work not necessarily just on housing. As part of our equity roadmap, we just announced a commitment with LISC to focus on small businesses that are owned by people of color, particularly Black-owned small businesses. And we've created a $60 million fund that will make loans available at low or no interest to Black-owned businesses across our footprint to help with this particular at this particular moment in our history, to help with the growth of those businesses, the ability of those businesses to thrive. So I think thinking about return on investment is going to be really critical, not just from a financial, but also from a social return on investment. And I want to go back to something Mark touched on really and double down on it. When we challenged ourselves first and said, okay, we know there are these 515 people in Oakland who are over 50, who have at least one chronic medical problems, who are on the streets. We need to figure out how to get them housed. We've gotten all kind of pushback from there's not enough housing stock. There's not enough affordable housing. You're not going to find enough places to get them housed. We said, okay, well, let's take all those challenges on. So we've created this fund as a flexible pool fund. I think we ended up spending about $7.5 million out of that fund to eliminate all those barriers that people face before they actually get into housing. And we've realized, actually, guess what? There are 515 units that are available. Maybe they're not all in Oakland, maybe they're in neighboring city, or or it could be a relative. We've created shared housing model that was extremely popular. And actually what we've heard, and I got a chance to talk to a couple of the folks who actually ended up being housed, the shared housing model was tremendously effective, not just because it was able to get them a unit or a space that they can afford, but it created the sense of community that a lot of these folks were struggling with. So I think we want to be really comfortable in challenging the status quo, challenging some of the assumptions, roll up our sleeves, and just do lots of the blocking and tackling. And I know we can find solutions.
Wonderful. And Bashara and Mark, maybe you might want to, I'm looking at a question here from the audience here in terms of attributes to our programs that we're looking at. Do they represent all genders, all ethnicities, youth, adults, seniors, those with various physical abilities, those from various income levels? I think, you know, we're really looking at this housing for all, and any of the programs and ideas that we're putting forth, are they really looking at wanting to bring everyone home? And what are some of your experiences around that, or how do you propose that everyone is seen in the efforts that we're making?
I mean, I can start. I mean, I think yes. And I think the beauty of this flexible approach that we're talking about is it's sort of a recognition that nobody, no matter who you are, should be subject to the trauma of living outdoors. And I think in this history of trying to solve this problem and sort of the intractability of it, policymakers, other people with great intentions have been seeking ways to stratify the population, you know, and to limit the numbers, to cut the numbers, to say, what do we need to do next, and so forth. So, you know, we've all seen these slogans that we have maybe had to adhere to for one reason or another to get funding, and that we're going to solve, you know, chronic homelessness by 2018. We're going to solve veterans homelessness by such and such. We're going to do this. And I think the reason this housing benefit should appeal to people is that it's not talking about that. No matter who you are, if you don't have the $500 it's going to take for you to get housed, the intervention is the same. So why are we splitting hairs here? And why are we going after this when it's that same $500 that, you know, a queer young kid needs to get off the streets, to a older African-American male who's been struggling in the Tenderloin for the last 20 years, to a woman and her kid who are just about to lose their one-bedroom apartment in Oakland? That doesn't matter. It's that monthly rent assistance that all of those people are going to need. So to me, it takes sort of the bias and the filter out of the equation, and it puts it into this sort of cut and dry benefit.
Wonderful. Well, I am looking forward to how all the discussions around that is going to continue to evolve, Mark. I am very mindful of time, and I definitely want to do a really rapid fire power round around what each of you think the call to action would be at this stage in the game. I want to make sure that you have some ideas that you could leave with folks that are with us today. Leave them with one thought of what they can do, or how the healthcare sector can do more. Doug? Oh, we can't hear you.
There we go. Sorry, I get to go first, huh? Yeah, so mine are pretty straightforward. I mean, it really is about cross-sector work. So I found that I think getting to know the other side of the aisle, as they say, is important. So joining a board can be really valuable. Public healthcare boards, and invite someone from public health or healthcare to join your advisory board or your organization's board, and get engaged. I mentioned briefly the community health needs assessments. Those are CHNAs. There's also community health assessments that public health departments do, and there's something called community health improvement plans. Lots of acronyms, of course, but all of those are required by regulation. And I think too often housers are not part of those conversations. So help engage with the local healthcare systems and public health departments. And the last is really, as well, is it's been really clear to me recently with the AFFH ruling, the Access to Fair Housing ruling, and the Community Reinvestment Act rewriting, that public health and healthcare need to weigh in. It's because these are not just housing issues, these are health issues. And so anything you can do, and this is why some of these relationships can be important, to help them weigh in from their perspective, bring the doctors and public health professionals along to help make sure high quality policy is continuing our expansion of affordable housing.
Thank you, Doug. And Bashara, what is your call to action? And if you can, as I'm looking also at a question in the chat box here, in the Q&A, if you could touch upon how healthcare organizations can further the anti-racist movement in the housing industry. I'm sure you've got a call to action around that.
Yeah, I think for me, there are two levels of call to action that I bring up to this group. One, on an individual level, I would encourage us all to be deeply involved in understanding what's happening in our communities, whether it's at a local level, whether it's your city, your county, it's the state level or a federal level. I think it's really important for us all to be educated at what's the chatter, what's the policies that are being discussed, and to weigh in. You know, call your alderman, call your supervisor, call your representative, call your congressman, and vote. And that's on an individual level, I think is going to be really, really important. And I also agree with Doug about the importance of engaging with sectors that are really close to the sector that you're in, but try be the bridge into a sector that you might not be very familiar with. You know, I didn't even know about impact investment for the longest. That's not what you study in medical school. I didn't know what a CDFI is, but I've learned and I got to know these folks and know how they think and know what they work on. So I think on an individual level, we have a responsibility. I think on an organizational level, for folks in healthcare organizations, I would definitely encourage you to learn about the Healthcare Anchor Network. I know Doug mentioned that in his opening remark. And actually, Rochelle, I remember how the Healthcare Anchor Network came together. It came together as a result of a conversation that was in Dignity's office. It was Pablo, myself, at the time I was at Trinity Health, and one of the folks at Kaiser Permanente at the time I wasn't at KP, where we said we really need to build a movement here and bring health systems together to think about these issues. And now the Healthcare Anchor Network has over 47 of the largest health systems in the country that are looking at how health systems can make a difference in housing, in investments, in hiring, and purchasing. So I would encourage you, if you're part of a health system, double check and see if your health system is not part of the Healthcare Anchor Network. Feel free to shoot me an email or Doug, and we'll make sure we get you connected.
Thank you, Bashar, for lifting up the Healthcare Anchor Network and our involvement there. And Mark, we will leave with you on the rapid fire here of what your call to action is. And I know that people are very interested in how we can continue this dialogue with you and how you're developing your thinking around the housing stability benefit, because I know people are very interested. So if you can include that in your comments as well.
Awesome. Well, we welcome everybody's input, and we'll figure out ways to get more input into it. And again, this is kind of our intro party here to it, and we're gonna build from here and so forth. And I mean, in terms of my, last minute remarks on this stuff and call to action. I mean, I think one thing is I'm calling for, let's stop doing things that we know don't work. We have done them and we do them over and over again for a sort of complex set of reasons, because we think politicians and HUD and others, this is the flavor of the year. And so this is what we're doing. But when you get down below it and you talk to people in the trenches who are doing this work, everybody's rolling their eyes. This rapid rehousing intervention is not going to work. 2 months of rent subsidy for this person's not going to work. It's too complicated and so forth. So I think at this point, 30 years into this pandemic of homelessness, we need to stop doing that. We need to move to the things that we've all seen work for people and resist going about our normal business and sort of accepting the status quo. And, I also think we should embrace how fantastic California is and what we've been able to do. You go back to, you know, the last 50, 60 years, we've been the leaders in every civil rights, human rights, equity, demonstrations, and so forth in this country. We've achieved amazing things, and it boggles my mind that we can't solve this. We cannot find $400 a month for that person living in the park. You know, that doesn't make sense. We're the wealthiest state in the nation. We have amazing technology. All the major tech companies grew out of California. Airbnb, a California company. Tonight, I can stick on my cell phone and get a treehouse reserved in, you know, the Yucatan. But I can't get on my phone and find where the 5,000 vacant units are in the greater Bay Area. Come on, we can do this. You know, we can get, you know, a vanilla lemongrass latte delivered to my door in 2 seconds. But I can't help this person living in downtown Berkeley get a, you know, 200 square foot unit with a bathroom inside. It doesn't add up in terms of what we're doing. So
Mark,
that's my call.
I love it. I love the way that you're completely stimulating our creative thinking, and I have the awful job of closing us out because I think we could go on for another 30 hours here. But thank you to Mark and to Doug and Bishara for the engaging dialogue and critical conversation about the catalytic partnerships between health, housing, and community development sectors, and all the wonderful things that you guys are doing within your organizations. And we need more than ever each other to go big and be bigger than what we're facing right now to bring everyone home. The power to reimagine and to act is really who we are. This is our wheelhouse, and this is the home that we stand on, the home we are to each other. And so I am just embracing all of you and all the folks that have joined us on this call today, because I do believe that we can get through this and that we need each other to go home, to bring everyone home. So before I close out today's session, we have 2 reminders for our participants. Enjoy your lunch break, but if you are interested, feel free to check out the HCD office hours at lunch and get all your HCD funding questions answered. You can access the office hours by visiting the agenda banner in Workcast. And don't forget to visit the exhibit hall following sessions where you can win prizes, including $2,500, complimentary registration to the next year's Housing California Conference, and more. We look forward to seeing you all again at 1 p.m. for a critical dialogue about why developers should run to organize their residents, building power for affordable housing, even in a pandemic. Thank you all for joining us, and we'll see you soon.
Thank you. Bye-bye.
Bye-bye.
Bye.